Good morning, students. So, today's topic is brain death and organ donation. Death is defined as an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of entire brain, including the brainstem. The mechanism of cerebral death is when intracranial pressure is more than the mean arterial pressure, that is incompatible with life. So the neuronal injury leads to neuronal swelling, and which again leads to increased intracranial pressure, that leads to decreased intracranial blood flow, that in turn leading to neuronal injury. So that is a vicious cycle which leads to increased intracranial pressure becoming more than the mean arterial pressure, that is incompatible with life. And why the test is required? Where brainstem death is suspected, it is highly desirable to confirm this by brainstem testing. So, to eliminate all possible doubt regarding survivability and to confirm the diagnosis for families in cases subject to medico legal scrutiny, and to provide choice regarding the organ donation. So, we have to confirm the brainstem death, that is, the person is completely dead. So, that is done by doing a brainstem testing. So, to all the possibilities of life, even small possibility of life, it has to be eliminated before confirming the death. So to confirm diagnosis for families and in cases subject to medico legal scrutiny, that is to do any medico legal procedures. Suppose the person is he has got suicide, has done suicide, or anything related to medico legal issues, that uh, confirmation of death very surely, very appropriately, it should be done by brainstem testing. And physiological changes with brain death. Death is a continuous ongoing process, not an isolated event, and total loss of neurophysiological functions of brain for more than 8 minutes confirms a total and irreversible loss of brain function. So it is a death is a continuous ongoing process, and it is not sudden isolated event. We can't tell a particular point the person is dead. So total loss of neurophysiological functions of brain for more than 8 minutes confirms total and irreversible loss of brain function. So there are many functions, that is the body is having cardiovascular functioning, pulmonary, endocrine, and then temperature regulation, metabolic and inflammatory state, or the normal cell tissue condition of the body. So all those are present. Along with it, the neurological is the main thing which determines the death of the person. So guidelines for determining the brain death are: a determination of death must be made with accepted medical standards. The American Academy of Neurology published in 1995 practice parameter to delineate the medical standards for determination of brain death. In India, brainstem death was legalized in 94 when the TOHO Act was passed, and the UK criteria for brainstem death are followed. The TOHO Act is Transplantation of Human Organs Act. In 1994, brainstem death means the stage at which all the functions of brainstem have permanently and irreversibly ceased, and is so certified by a board of medical experts consisting of the medical superintendent in charge of the hospital in which brainstem death has occurred, and a specialist nominated by MS in charge of hospital from a panel of names approved by the appropriate authority, and neurologist or neurosurgeon nominated by superintendent in charge of hospital and the doctor under whose care the brainstem death has occurred. So, brainstem's death has to be certified by a board of medical experts consisting of the superintendent of hospital and a specialist and a neurologist or neurosurgeon, and also the doctor under whose care that person has determined as brain death. And steps in determining the brain death are: clinical diagnosis of brain death should be performed in 3 steps: establishing the etiology of disease and excluding certain potentially reversible syndromes that may produce signs similar to brain death, and demonstrating clinical signs of brain death by coma. That suppose the person is in coma, we have to determine the brain death by doing some clinical procedures, and brainstem reflexia and apnea. So in these conditions we have to do the clinical signs so that we can confirm the brain death. So brain death should not even be thought of until following reversible causes of coma have been excluded. So these are the reversible causes of coma, like intoxication, when the person has been intoxicated by alcohol and drugs which depress the central nervous system, and muscle relaxants, and primary hypothermia and hypovolemic shock, and then metabolic and endocrine disorders. Hypernatremia and diabetes insipidus is more often the effect rather than the cause. So the most common cause, a reversible cause of coma, is intoxication and drugs, and also muscle relaxants and shock. So we have to eliminate these causes before confirming the diagnosis. And irreversible cause of death are: neurological assessments may be irreversible cause of death is by neurological assessment, which may be unreliable in acute post-resuscitation phase after cardiorespiratory arrest. And in cases of acute hypoxic ischemic brain injury, clinical evaluation for neurodevelopmental delay should be delayed for 24 hours subsequent to cardiorespiratory arrest. Core temperature must be more than or equal to 34 degrees centigrade to proceed with the formal testing. And the brainstem activity can be examined by measuring the pupil size, which is more than or equal to 4 to 9 mm, and it should be unresponsive to light, and the movement of jaw or lids excludes the neurodevelopmental delay. And vestibulo-ocular response by testing the oculocephalic reflex, that is doll's eye, and pharyngeal, that is stimulating the posterior pharynx, which elicits the gag reflex, is absent, and suctioning by the endotracheal tube and seeing for the swallow reflex, and also apnea test. So the doll's size means mechanical or gravitational forces stimulate the vestibular responses, and cold calorics is the thermal energy stimulates the vestibular responses. Normal response is eyes always gaze up towards the roof, and rapid but steady movements and observe for direction of the gaze. Activates the vestibular system ipsilateral to head thrust. So you can see in the picture when eyes are turned head to left and eyes are turned to right, and central is everything normal, central is normal response, and head to right and eyes to left. So head to one side and eyes to one side. So that is by activating the vestibular system ipsilateral to head thrust. Communicates with the contralateral horizontal gaze center and simultaneously dampens contralateral vestibular tone. So cold caloric testing. So this is all regarding the vestibular apparatus. And apnea test is, for the apnea test, the prerequisites are normal core body temperature and systolic BP more than 90, normal PaCO2 equal to 35 to 45 mmHg, and absence of any other underlying condition that could confound diagnosis by mimicking brain death and suppressing respiratory drive. So pre-oxygenate with 100% oxygen for 30 minutes and connect a pulse oximeter, then disconnect the ventilator and place a nasal cannula at the level of the carina. Give 100% oxygen at 6 to 8 liters per minute during the test. Watch closely for respiratory movements and draw ABG equal to 10 minutes and reconnect the ventilator. So that apnea test is positive, that is supports the diagnosis of brain death if there are no respiratory effects during the test, and repeat the ABG shows PCO2 more than 60 mmHg. So that is no respiratory efforts during the test and repeat ABG showing more than 60 mmHg of PCO2. So that indicates a positive brain death. And the test is indeterminate if after 10 minutes the patient demonstrates no respiratory effect but CO2 is less than 60 mmHg and it is negative, that is does not support the brain death if patient demonstrates any respiratory effort at any time during the test. Cease the test and reconnect the ventilator immediately. So if the patient becomes unstable at any point during the test, that is SBP drops less than 90 and significant desaturation on pulse ox and observation of cardiac arrhythmias, the test should be aborted. It should not induce a code. In severe lung disease, caution must be exercised in considering the validity of the test. If in physician judgment there is history of suggestive of chronic respiratory insufficiency and responsiveness to only supranormal levels of CO2, or if the patient is dependent on hypoxic drive, and if the physician cannot be sure of the validity of apnea test, an ancillary test should be administered. So ancillary should be understood to mean an alternative test to one that otherwise for any reason cannot be conducted. And the gold standard is global absence of intracerebral blood flow by doing the cerebral angiography or radioisotope scan. So that is the ancillary or the other alternative test to the normal what is this apnea test. And the accepted ancillary tests are the cerebral angiography. So here no intracerebral filling at the level of the carotid bifurcation or circle of Willis, and the external carotid circulation is patent and filling of superior longitudinal sinus may be delayed. An isotope scan by technetium 99 hexamethylpropylenamine oxim brain scan shows no uptake of isotope in brain parenchyma, that is hollow skull phenomenon. And radionuclide cerebral scanning cannot document absence of flow in the vertebrobasilar circulation. And PET scanning by glucose metabolism studies, so normal hollow skull sign and cerebral metabolism reduced to less than 50%, equal to 50%. Insufficient ancillary testing is by transcranial Doppler ultrasonography. And a silent EEG, for example, can be consistent with brain death. It can also be consistent with pharmacological influence, that is anesthesia or drug intoxication. By contrast, EEGs don't always confirm brain death. There can be minor transient EEG activity even in the setting of clinical brain death. Electrical artifacts in EEG in the ICU setting have been described. So this is a picture on MR angiography. And somatosensory evoked potentials. In studies of patients with brain death, most patients had no responses to tests for somatosensory and brainstem artery evoked potential. It is therefore useful in distinguishing isolated brainstem death from high cervical transverse cord lesions and focal bilateral lemniscal lesions. So key to understand is that none of these confirmatory tests is sufficient in and of itself to diagnose brain death. They are merely adjuncts. So in children, specifically in children, the tests should be same as those in adults. All these may be carried out twice at an interval of at least 6 hours according to the accepted protocol, and children are more resilient than adults. A longer time between assessment has been advocated. The patient must demonstrate no response to any stimulation. Spontaneous movement is always absent. Seizures, shivering, any posturing, etc., indicate brainstem function and is not consistent with determination of brain death. The presence of spinal reflexes does not exclude brain death, but if there is any doubt, then the diagnosis of brain death should be withheld. Conditions distinct from brain death: persistent vegetative state, locked in syndrome, minimally responsive state. So, persistent vegetative state is that normal sleep wake cycles are present and there is no response to environmental stimuli, diffuse brain injury with preservation of brainstem function. So, locked in syndrome is ventral pontine infarct, complete paralysis, preserved consciousness, and preserved eye movement. Minimally response state is diffuse or multifocal brain injury, preserved brainstem function, variable interaction with environmental stimuli. Observations compatible with brain death: sweating, blushing, deep tendon reflexes, spontaneous spinal reflexes, and Babinski sign, and motor responses, that is Lazarus sign, may occur spontaneously during apnea testing, often during hypoxic or hypotensive episodes. They are of spinal origin and they include spontaneous movement of limb other than pathological flexion or extension response. So remember that clinical exam is the cornerstone of brain death determination, and there is no test or substitute for an examiner's judgment and skills. So after brain death, one option which is majorly carried out nowadays is that organ donation. So it has been one of the greatest advances of modern science that has resulted in many patients getting a renewed lease of life. It means that a person pledges during his lifetime that after death, organs from his or her body can be used for transplantation to help terminally ill patients and giving them a new lease of life. So in India, every year nearly 5 lakh people die because of non-availability of organs, and this number is expected to grow due to scarcity of the organ donors. So the common outcome of the dead person is uh, all these days you can see here, and the outcome can be changed by donating the organs. So, what is the need? Corneal blindness is very common in India. More than 3 million cases in India are of corneal blindness. So, 60% are less than 12 years of age group, and only 1.5 lakh per year corneal donations in India are taking place. So, the need for the organ donation is that donor crisis is severely present in India. So, need versus availability of organ donors in India annually, you can see in the picture. And the types of organ donation are living related, that is, donor remains alive and donates a new renewable tissue, cell, or fluid, blood, or skin, or donates an organ or part of an organ. And living non-related is that in case of brain death and cadaveric donor. In brain death, organs are kept viable by ventilator or other mechanical mechanisms until they can be excised for transplantation. So the living donor can donate blood, kidneys, bone marrow, part of liver and part of pancreas. Commonly donated organs from brain death are kidney, cornea, heart, lung, liver, pancreas, skin. And cadaveric donor tissue may be recovered from the donors up to 24 hours past the cessation of heartbeat. So they are the major source of organs and tissues. So the types of organ donation are brain dead persons are kept on artificial support, and most cases of brain death are the end result of head injuries or brain tumor patients from intensive care in units. It is possible to donate all organs in the case of brain death. Cardiac death. So due to lack of circulation of blood, the vital organs quickly become unusable for transplantation. However, if the person is on ventilator and if it is medically clear that person cannot survive, then family can consider organ donation for certain vital organs. Almost everywhere organ donation is voluntary. So two voluntary systems include opt-in and opt-out. Opt-in means where the donor gives consent, and opt-out is anyone who has not refused is considered as a donor. In India, we have the opt-in system while many Western countries practice the opt-out system. So, consent for organ donation. A patient's previously expressed preferences for organ donation are paramount. ICU clinicians and coordinator should retrieve proof of such authorization. Current state of Organ Donation Act, it is proposed to amend that Transplantation of Human Organs Act by changing its name from Transplantation of Human Organs Act to Transplantation of Human Organs and Tissues Act. Law will broaden the definition of near relative to include grandparents, grandchildren, uncles, and aunts, and also not so close relatives who have stayed with the patient can donate organs provided there is no commercial dealing. And Human Organ Donation Registry coordinates the process of cadaver organ donation. During lifetime, a person can pledge for organ donation by filling up a donor form in the presence of two witnesses. The organ donor form could be obtained from HODR either personally or through mail. Contraindications to donation are the conditions like hepatitis B or C may be acceptable for those patients, and IV drug abuse or practicing homosexual, and untreated bacterial, fungal, or viral infection, and malignancies other than primary brain tumors and non-melanoma skin cancers. ICU management of brain dead potential donor. Stabilize profound physiologic and homeostatic derangements and balance competing management priorities between different organs. Avoid somatic death and loss of all organs. Hemodynamic changes with brain death. So 10 to 20% donors are lost to cadaveric collapse as patients evolve to brain death. Volume depletion in brain death causes are multifactorial, and 50% of potential brain death donors are volume responsive. Critical care management of potential organ donors is crucial in maximizing the number and quality of transplanted organs. So, the goal is to provide adequate oxygen supply and tissue perfusion. Organ preservation time for various organs like heart 4 to 6 hours, lungs 4 to 6 hours, liver 12 hours, pancreas 12 to 18, kidneys 72, small intestine 4 to 6 hours. So, thank you all. I hope you understood the topic. So, brain death, identifying, diagnosing the brain death, and confirming it by doing various tests, and then finally, uh, the Organ Donation Act, so which is of opt-in and opt-out systems. We are following in India opt-in system, and the donor should be filled while he is alive. He has to fill the organ donation form, and he can readily donate the organs. So thank you all.